Dr. Buddy Hammerman, who has really put this together with a great panel of professionals to work us through some of the intricacies of the Affordable Health Care Act and the impact it will have on our healthcare system. Last year, we started conversations about this because it is confusing and because the rhetoric on the television is hard to follow. Is it a good thing? Is it a bad thing? What should we feel good about? What should we not feel good about? And so it seems a great time, and we're lucky to have this resource in our community to put together people that can answer some of those questions, to answer how we look forward with this. So with that, I hope that this evening provides a chance for you to learn, to be inspired, and to ask questions. The sessions will go, we have some slides that will last and some presentations that will last a little over an hour, and then there is time for questions and answers. I hope that all of you have a pen or a pencil. If you don't, I'd be happy to bring one to you, so that if there's any questions that come up during the presentation, we can jot those down. I'd like to offer a special thank you to Joe Daly for all the work he has done helping us get set up and ready to go tonight. And with that, I can go.
Thank you very much, Rachel, for inviting us to be here tonight. And again, I think this is a very timely topic. Obviously, you can't go by a day without hearing some sort of media frenzy about what's happening with Obamacare or the Affordable Care Act. We have a really talented bunch of participants here today, and as we go through the talks, I'm not going to formally go through their extensive and impressive biographies, but certainly take a look at them, and I think you'll find it to be so that these folks, intrinsic to our communities, have a significant amount to offer us, both locally and nationally as well. I'd like to thank them for participating, in particular Pam Langen, who will be a part of the panel discussion, was very helpful and supportive in providing insight, and some of the things that you notice in your brochures are a part of her pathway in forming the glossary as some of the questions that will be posed at the end, and I really appreciate her participation and her help in that context. So without further ado, let's talk a little bit about the changing landscape of American healthcare. All of you have felt it in some sort of way. I talked with some of the medical club members tonight, and they're affected both personally and as well as through the things that they hear, and it's ever changing. So as we look at this process, I'll ask you just briefly for a shout out in terms of some trivia. So who are the two folks in the left panel? And I'm afraid the STEM students will probably not know this. Right? And his partner's name? Come on, we can do. Come on, Adam Rudderman. Anybody? Steve Kiley. So that's Steve Kiley. And a lot has obviously changed over time. In the right panel, STEM students, who's in the right? That's Grey's Anatomy, right? Not many that are out there. But we're evolving. And as Socrates once said, that the secret of change is to focus all of your energy not on fighting the old, but on building the new. And as a physician who's still actively practicing, as well as a physician who's in a leadership mode, in a management mode, we've got a long ways to go to focus that sort of energy in moving that forward. It is going to be very important for us to adapt to the healthcare reform model, and you'll hear a number of very innovative, very strategic, very creative ways this evening that folks are dealing with this concept. In terms of this new era, so this new era, the bill was signed in 2010, then supported by the Supreme Court, and really has two basic notions in terms of the Affordable Care Act. That is to provide for those that can't afford care or those that can't get care through their employers, as well as really create a structure around the cost of care, particularly in regards to Medicare. that is CMS, and particularly in regards to waste in the system. Some of those things that are innovative in our world involve accountable care organizations. You've heard of ACOs, as well as bundling strategies, bundling the cost of care from the time you come into the hospital all the way until the time that you get home and then actually get well with your primary care physician. So that there's a one-stop shop, essentially, to deal with that issue. Private insurers play a very substantial role in this context. You'll hear from one of the speakers tonight in an innovative sort of way, a process that's being designed and looked at in terms of the healthcare marketplaces. So we're going to just touch base, and because we've got some very short time here to discuss a very broad topic, the physician's perspective. We'll talk about the population health issues as well as medical homes and innovations. Lynn Miller will be attacking that. The insurance industry from the perspective of Brian Rinker and his colleagues at Blue Cross in terms of healthcare exchanges and new strategies. We'll talk about the health IT environment with Jim Youngkin and lots of opportunities. And for those of you students out there and young folks, this is an enormous opportunity that exists with respect to science, technology, engineering, and math in the landscape of new healthcare reform, as well as hopefully some questions from you all in terms of moving forward. You'll see two panels here, and they're somewhat difficult to read, but essentially I'll tell you that on the left are the caricatures of two physician groups. And what's happening is that by and large, the employed model of physicians is taking a huge effect. From 2012 to 2013, 21% of physicians were in private practice, now down to 15%. This is based on a Jackson and Coker survey model. That's a group of folks that looks at physicians, employs physicians, helps physicians get positions in their communities. And the number of docs is increasing substantially that are employed. It's projected that in the next 5 years, 90% of physicians will be employed. The problem isn't so much the employment model, it's the number of physicians that will retire from medicine, and we're not going to be able to backfill their positions. 18% will retire in the next 5 years, and another 36% will retire in the next 10 years. So we won't have the bulk of physicians necessarily that we need unless we wrap our arms around why they're leaving medicine. And they cite several reasons. Some of those reasons include burnout. Over 60% of physicians cite that. 60% may include issues with medical malpractice, overhead, electronic medical records. And then another specific percentages that have been looked at include reasons behind the change in healthcare, quote unquote. So that's going to be an issue for us to grapple. Lots of people overseeing what we do. In the panel to my on the left-hand side, you see the doc sitting there at his computer, dictating his electronic medical record progress note, but lots of folks around him. That's ACOs, that's the accountable care organizations. That's CMS, that's Medicare. Okay, that's your payers, so your private healthcare entities as well. But you see there's some positives in the Affordable Care Act. You see there are individuals that will now be covered. So you're going to see more patients as a doc, which may or may not be so good, but they're going to be paying patients. There's going to be money that's going to be laid out for screening purposes. So things in terms of preventive measures, things in terms of looking for screening for diabetes or hyperlipidemia or issues such as vaccinations. More support for the electronic medical record, and I'll leave that to Jim Youngkin to talk a little bit about where that plays into it. A greater role for physician extenders, nurse practitioners, physician's assistants, as well as pharmacists. They're going to play a greater role in what you see in terms of healthcare in the growing several years. As well, there's going to be a broader role for telemedicine. Because again, if we don't have the docs to support it, we don't have the providers at the bedside, we're going to have to look for innovative technologies to bring them into the fold. So in an excellent blog in Leadership Forum in October 2013, Dr. Stephen Klasko, who is now the president and CEO at Jefferson, talked a bit about transforming, not reforming. So transforming of physicians to really simplify care processes, make them easier to contend with. Decision support models. So those are software techniques that could play into the way that we diagnose and treat disease. Look at telehealth, as I mentioned, as well as other information technologies. And those are really occurring in your own backyard. And we'll talk a bit about that amongst the speakers. Population health. Len Miller will talk about this, but personalized medicine at the same time as treating a large group of folks, you really can to pin it down to an individual's genome. We have a lot of access to the genome now, so we can actually personalize this kind of care to direct a better diagnosis and potential therapeutics. Effective teams between healthcare practitioners and providers. Boy, if we could communicate better and create teams better, I think we would reduce the redundancy in the care. Coordinate care, that's very important, and I think Lynn's going to talk a bit about that, as well as look at incorporating performance measures. You know, docs are on report cards now. As little as we want to say that, like SEM students out there, we're not quite on the trimester. But certainly we'll have to contend with those issues as well. And we'll have to be accountable for what we do, not only as docs, but as organizations moving forward. And the federal government is part of that pathway. But as physicians, we need to be leaders and help make those decisions that make sense in the long run in terms of those measures. And we need to accelerate physicians' ability to adapt to this. And physicians are a difficult bunch. They're taught in medical school to certainly be individuals and be creative in the way they've gotten there. But we also need to know that we have social, we have ethical, we have financial responsibilities to the entire society as a norm. The medical futurists are out there. In the left-hand panel, it's difficult for you guys to see, but in green are a number of new digital technologies, as well as those in red and orange that are evolving fairly quickly. And I think that we as docs have some capabilities now in terms of digital technologies. There's a knowledge set called UpToDate that we can use certainly on mobile devices or on the computer. And UpToDate means that actually these are updated every 30 to 60 days, pieces of new information that are evidence-based that allow us to practice in a concordant fashion with the standard of care. Online simulation training. I talked a little bit about this with my group at dinner. But essentially, there's something called SimMan and others to really practice and hone your techniques with. There are even simulation training scenarios that include interviewing patients. And I think we could all do a better job with that. Digestible sensors, you can swallow a camera. And we've known that before, but the technologies are getting better and better, where they can hone in on the diagnosis much easier. Robotics, I'm sure that you've heard in some way of the Da Vinci robot that can do prostate surgery and other types of surgeries. They're really available right here in our own backyards. And they're going to be refined more and more, as well as prosthetics that are robotic in nature. Telemedicine, I touched base with you on that a little bit earlier, but any type of specialty essentially now can cone in with high-resolution cameras in terms of being able to diagnose and treat disease. And then artificial intelligence and decision support. So we're going to be able to use software technologies to help us make decisions on patients. Not fully, but they're going to be a part of the mix in terms of helping us move forward. So in conclusion here, not to embarrass my kids, I didn't suggest on the left-hand panel at this young of an age that they go into medicine. But I certainly didn't think 10 years down the road that I'd be standing on a stage here in Wyoming Valley talking about the evolution of healthcare. But I think that where we've gotten to, certainly in space and time, is what we thought we knew, we haven't really learned yet. And John Wooden, who's one of my favorite folks of all time, stated it's what you learn after you know it all that counts. Sometimes we think we know enough about what's going to happen that we don't take a step back to learn a little bit more about what's actually right here, right now, And I think that we don't know what's going to happen in terms of healthcare, but we have to be a participant rather than sit on the bleachers and see what happens. So with that, I'd like to invite our first speaker up. I've worked with Lynn Miller in the past at Geisinger, and she will talk a bit about population health as well as innovations surrounding primary care physicians. Lynn is executive vice president and in clinical operations for Geisinger Health System, and I really appreciate her coming tonight to speak to us.
At the bottom. It's on the bottom on the.
Technology problem. No, this one, it's just I can't get up all the way. All right, not an Apple user. It's clear, isn't it? So my son is the webmaster for the school district in Philadelphia. He needs to do some work with his mom. Okay. All right. Okay. Oh, great. Okay, that's the confusing thing. All righty, population health. So how do we create systems of care? So Buddy talked about some of the challenges with the new healthcare legislation. Some of the challenges for us on both the insurer side and the healthcare provider side is really to be able to create a system of value for our patients and to have the patients be really part of the healthcare team. So population health is about taking responsibility for the care of a population. And when you look at population health and you look at patients or consumers of healthcare, there's three really bundles of that. There are the people who are low risk, and that accounts for about 60 to 80% of the population. That's most of us, the walking well. Then there's the group that you want to keep out of the hospital that may have early onset of some disease, whether it be diabetes, some of us gaining weight, middle age, etc. About 15 to 30% of the population is there. And what you want to do is keep them well. And then the 5% of the population that really uses the most of the healthcare resources are the people that you really want to use most of your resources on and really, really keep those patients out of the hospital, keep their disease under control, and or if it's end of life, use those resources appropriately. What we've tried to do, and I'm going to use Geisinger as an example, is really look at how do we redesign care so that we're creating a value proposition for both our patients, our members for the health insurance, as well as the organization as a whole. And if you look at the top of the pyramid, that's the value-driven care. So you'll hear things in the news about medical home, about really redesigning healthcare. So some of the things that we've tried to do is to really transform the culture. And Buddy talked a little bit about how that's difficult for physicians. I think it's difficult for all of us in healthcare. We're used to doing things in a certain way. We're used to having a relationship with our primary care physician, with our doctor. And so we've got to think about things differently. We also need to use information. We have a lot of information on our patients and members that we need to use to really keep them healthy and really take care of patients. And so I'll talk about some of the specific things, but we've talked about medical home. We talk about putting healthcare providers in environments that they haven't been in before. So when you're in a long-term care facility or a nursing home, how do you make sure that patients don't get readmitted to a hospital? Those kinds of things. Buddy talked a little bit about the continuum of care. We used to talk and think about episodic care. So care where you go into a hospital, you get treated for your illness, whether it's appendicitis, a gallbladder, pneumonia, and then you're discharged from the hospital. What we're trying to do to really create value is to look at all of those episodes as a continuum of care. So the patient, before they enter any episode of care, before they go into a hospital, and then the patient after they're discharged from the hospital. What's that next destination of care? So in healthcare anymore, there's lots of partners for the patient. It used to be just your primary care physician. So now there's more people around the patient. There's a whole team of providers. And there's the insurers, there's the hospitals where you have an acute stay, specialists. And then also now, the government is involved because as we heard today on the news, if anybody listened to NPR, they put out some statistics that there's 6.1 million more people who have insurance now than had it December 31st. I don't know if those numbers are correct, but that's a lot more people that have insurance. I tried to do something where I thought if we took this from a patient's point of view or somebody who's a consumer of healthcare, a patient used to be used to talking to one provider, their primary care physician, and they had that relationship with that provider. Now, if you look at the healthcare environment, there are a lot of people around a patient. So if you look at Mrs. B, she has her PCP, her primary care physician, but in that office there's also the nurse, the medical assistant. There's people who will talk to her specifically about her disease. There may be a pharmacist in that office that really works on medication management, making sure that a patient takes their medications to keep them well and keep them out of the hospital. So all of those people work around the patient and make sure that they're all doing the right job. So you don't want the physician to do something that a medical assistant could do or a nurse could do. You want to make sure that the physician is seeing as many patients as he or she can possibly do to make sure that, as Dr. Hammerman talked about, we are seeing less and less physicians as physicians retire, more population to take care of. We want to make sure that we really have the right resources. We also have no need to bring patients always back into a doctor's office. We can take care of a lot of health care, our own health care, by really interacting with a computer, talking on the phone, etc. We have opportunities with the data that we have on patients to actually reach out to a patient on their birthday and let them know what they haven't had, what health care they haven't had. So for example, for somebody who's 50 or over, you should have a colonoscopy. Okay, you should have a procedure that checks that all of your GI system is working appropriately. And in order to get patients to do that on a regular time frame, when they should, you get a reminder letter on your birthday that says, Mrs. B, you are 50 years old, happy birthday. These are the 5 things that you have not had done in the last year that you should come. It's a nice birthday. So telemedicine is another thing. So if in fact somebody has diabetes, they can measure their sugars on a daily basis and actually enter it into a computer, and then their physician or their nurse in the office can actually look at their history. Don't have to come in, don't have to necessarily go to a lab. Really makes it a lot easier for people to be much more compliant with their health care. So there's a lot of people working around the patient. some that they see and interact with, and some that they don't. So that information, in order to send that letter, that all comes from information technology, from systems that have information about the patient. So there are a lot of people partnering with the patient. In the PCP office, any work that can be automated, so before the patient comes in, they can actually interact via a computer that says, these are the things that I want to discuss with my PCP. These are the things I want to discuss with Dr. G when I come in. And any tests that have been done could also appear there so that Dr. G knows when Mrs. B comes in all of the things that need to be done. And so it really creates some efficiency. They specifically focus on each other and don't have to be rumbling around looking for information in tests. The medical assistant is an extremely important part of the healthcare team in the office, can do all of the kinds of things pre-visit, and again, those things make it much more efficient for the patient as well as the physician. There is an RN embedded in the office to make sure that those patients who I said were at the 5%, who are the sickest patients, really get all of the care that they need. And they actually have a personal interaction with the patient, both in the office, but also via telephone. So they really make sure that the patient, if in fact they are discharged from the hospital, land at home appropriately, take all their medications, make sure they get their prescriptions, any problems or questions after they've been discharged, to make sure that they don't get readmitted to the hospital because they have not done what they should have done when they left the hospital. Jim is going to talk a lot about IT, but again, a big partner for us in the healthcare environment as we get more and more information about patients and more information compiled in one place. We have heard more and more about meaningful use, some of the things that Dr. Hammerman talked about with physicians being frustrated. Some of it has to do with some of the reporting that has to be done, and certainly the information technology people, the people who actually support the computers, are extremely important. Hospitals are key as far as partners in the healthcare environment, and again, we have focused a lot on being in the hospital, taking care of the patient when they're in the hospital. What now over population health is, how do you transition the patient to the next level of care? How do you make sure when Mrs. B leaves the hospital that she knows she's discharged today? She'll get a phone call from her case manager, her RN nurse, the next day. She has home health care within 48 hours, and then sees her PCP in 1 week, and then follows up with her specialist for a month. In the past, we would do exactly what discharge sounds like. We would discharge a patient, send them home, and not have a plan of care for them for the next week, the next month, etc., and really have a plan for the patient to follow. So population health and all of the technology around that and that redesign has really ensured that for the patients. Specialists, the connection with specialists also, it's one care team. The interaction between the specialist and the primary care physician and the patient is extremely important. There are handoffs, there's information that goes back and forth, and it's seamless for the patient, and that is extremely important. I don't know how much more we can focus on that, but to make it as easy as possible for patients and physicians to interact. Skilled nursing facilities, if you look at skilled nursing facilities, when a patient goes to a long-term care facility after a hospitalization, whether it's a rehab for a broken hip or a knee whether it's a pneumonia or whatever somebody's going to a skilled nursing facility for. One in 5 patients is usually readmitted to the hospital within 30 days. Every readmission to the hospital is stressful for the patient, it's difficult for the patient, it costs more money, and takes longer for the patient to be rehabbed. What can we do to create a better environment in a skilled nursing facility? One of the things that we have been working on at Geisinger is putting what we call a SNFIS in the skilled nursing facility. So someone an advanced practitioner or a PA who actually follows patients while they're in the nursing home, partners with the nurses in the nursing home and the administrators, and tries to keep the patients out of the hospital. Again, an innovation that we're trying. The big connection in population health is working more with the insurers. So the insurers and the providers working together to actually share information and focus on the patient. So what the insurer has is information about the patient, and then the provider and the primary care physician reacts to that information, uses that information around the care of the patient. Some of the things that the insurer has are predictive modeling, being able to really segment the information and really focus the primary care physician on the right information. So in summary, the whole idea and the concept of population health is really focusing our teams, virtually integrated teams, as well as teams that are in the same space, to really work around the patient to keep the patient as healthy as possible and keep them out of an acute care facility. Sharing information that's actionable and really engaging our professional as well as our patients on focusing on care. And then the goal is to improve outcomes and really create value for our patients. So there are many people working around Mrs. B to keep Mrs. B as healthy as possible and to keep costs down. Jim?
Our next speaker, Brian Rinker, who's the Senior Vice President at Blue Cross of Northeastern Pennsylvania, will talk to us about the insurance industry, as well as healthcare exchanges and innovations. And as long as we can get this working, we'll be all set, right? I'm not sure what's
Thank you. Well, thank you all thank everybody for inviting me to participate in the panel, for inviting Blue Cross. When I first got the call, they said, I'm Dr. Samuel Hammerman, but you can call me Buddy. Okay, I'm Brian Rinker, you can call me Pal. And there's a bit of a scorecard issue, so there's 4 people in the panel who either are at Geisinger or did work at Geisinger. There's 1 from Blue Cross, and there's 1 from CHS. So Cora and I talked. I'm going to go for about an hour. Cora's going to take an hour, and then if there's anything left, the rest of the guys can have that. We're actually lucky to have all the folks here from Geisinger, from CHS, and from Blue Cross. So my role is to give you the insurance industry perspective and not be an infomercial for Blue Cross, but try to speak from the industry as a whole. So I'll try to do that. What specifically am I going to cover? Well, We've talked about healthcare reform and the Affordable Care Act, ACA. Well, let me just kind of define a little bit about why it came about, what the goals are of healthcare reform, and what the key provisions are within the law. Now, this thing is incredibly complicated, so I'm going to try to keep it at a high level because I know you don't do this, most of you don't do this for a day job like us. But I think we can accomplish the goal of giving you at least a background. And then I'll tell you what the industry thinks, which is biased, because we're all biased. I'll tell you what we think about the pros and cons, what the experience to date is. And if you've got a TV, a radio, a newspaper, you know what the experience to date is. I'll just kind of comment on that. And give you some samples of innovation in our industry in health insurance. So why reform? 3 reasons. 1, the system covers too few people. 50 million people don't have health insurance. You'll hear a number 40 million, you'll hear a number 60 million. The average is 50, 40, 50, 60. It's a lot of people who don't have insurance. And in a country as modern as this, it's unacceptable. So that drove healthcare reform. It costs too much. We spend more percentage of GDP than any other country on healthcare. Spend a lot of money. And we've created a wonderful system in terms of advancements in technology. So people come here from other countries to get high-tech care. But where we fall short is on the third issue, and that is our health status indicators aren't good. For all the money we spend, we're obese, we smoke, there's too much incidence of disease, so we're not doing a good job of keeping our people healthy, so that's the left side of the equation. And then when people do get sick, we should have reliable outcomes. Mentioned before, getting your colonoscopy at 50. That's standard practice, so if you're not getting your colonoscopy at 50, there's a problem. And you're not going to get the right outcome in terms of healthcare screening. So those things drove the impetus, the energy, to let's have healthcare reform. So, and the ACA is a law. So law has provisions. So remember, this thing's a law. So we're going to have to go back and say, well, okay, what elements of the law were passed that go after these goals? So something happened on the way to the forum. Because it started out as healthcare reform, and then the actual goals of the ACA came out. And these are specifically reduce the number of uninsured, make health insurance more affordable, make health insurance fair and easy. And I'm not going to debate with you at all that health insurance did need reform. It did. But we kind of lost a little bit of the healthcare reform. And maybe my peers will agree or disagree, but we kind of spent a little bit more time on health insurance than we did on healthcare. And they'll do a better job of talking about healthcare reform than I will. So I'll focus on healthcare, but it's really about health insurance reform, and again, desperately needed. Okay, so let's take the goals and pick the key provisions within the law that are going to attack the goals. So goal number 1, reduce the number of uninsured. There's 2 provisions in the law that are designed to do that. The first is an expansion of the Medicaid program, medical assistance. That's a health insurance program funded by the federal and state governments and administered by each state. It's designed to protect people of low income, special needs, specific focus on women and children. So there's guidelines. If you make so much money, if you make more than a certain guideline, you don't qualify. So the law said, well, let's raise the percentage of federal poverty level. Let's raise that to 138%. More people will qualify, and they'll get their insurance through medical assistance. The second big issue was to expand the commercial insurance. Geisinger, Blue Cross, Cigna, Aetna, United. People whose insurance comes from their employer, like me, through Blue Cross or Wyoming Seminary, or an individual who might have their own business and they buy insurance on their own. Well, how are we going to do that? Well, we got carrots and we got sticks, right? The carrot is we're going to provide financial incentives to have insurance. And the stick is we're going to have penalties if you don't. So you'll hear words like mandates, penalties, incentives, subsidies. It's all about money. If we want to have people buy insurance, we're either going to say, we're going to penalize you financially if you don't, or I'm going to give you a financial incentive to do it. So the second big issue, which my peers will spend more time on than I will, is make health insurance more affordable. Well, health insurance, if you look at the cost of $1, 15 cents is spent at the insurance company and 85 cents is spent out in the provider community. So you could and should do health care insurance reform, but if you really want to get affordability, we're going to have to talk about the 85 cents. And I think there's some really talented people who do that. So how are you going to do that? Well, the first idea is we'll improve the overall risk pool. We'll get young, healthy people who don't have insurance to buy insurance. How are you gonna do that? We'll penalize you if you don't. We'll penalize you if you don't. So if we get young and healthy people to buy insurance, they can help subsidize the people who aren't healthy. Very similar to the Social Security issue that we're faced with in the country. I have a little bad news, and that is the stats just came out yesterday, and the most people that are signing up are over 55 years of age. So we've got to address that. We've got to get the young invincibles, right? They don't think they need health insurance to buy health care. Medicare payment reform, you're going to hear about ACO. You've heard about ACOs, and you'll hear more about ACOs. I'll only say one thing. We want to change the system from paying for volume to paying for value. So we used to pay every time there was a pill dispensed, every time somebody did a procedure, every time somebody did a test, every time somebody went to the hospital. Whether the person got better or not, or whether they kept them healthy or not, was irrelevant. We paid based on the volume. The design now is to pay based on keeping diabetics from going to type 2, keeping people from going into the hospital, a whole new way of thinking. So how do you make health insurance fairer, which says it wasn't fair before, and some people think it certainly wasn't, and how do you make it easier? Because it's such a complicated thing. I work in it every day. People call me, my friends, saying, can you help me with my insurance? And I have a hard time, even though I spend most of my days and some of my nights with it. So the first way to make it fairer is to eliminate a thing called pre-existing condition. So if you went to buy health insurance before healthcare reform, and you already had cancer, or you already had heart disease, or you already had diabetes, the insurance company said, you can buy the insurance, but we're not going to cover that condition, because you already had it. And the point they were trying to make at the time was, you don't wait till your house is on fire to call the fire insurance company, because that's a little bit too late. But that's now off the table. There are no pre-existing conditions. And the insurance companies use a thing called medical underwriting. Very simply put, the sicker you are, the more I charge you. The more healthy you are, the less I charge you. That's now been eliminated. We can still rate based on age and whether you use tobacco, but at the end of the day, the rates are going to be a lot similar. Well, just watch this again. Somebody asked again, so is healthcare good? Is healthcare reform good or bad? Is there winners or losers? And the answer is definitively yes. Because people who are paying a lot now are going to get a break and pay less, and people who aren't paying much are going to pay more. I'm not making a judgment on that. That's just the mechanics. The second big thing is it's very hard to talk about comparing product one for product two and company one for company two. So let's standardize the benefits at least. And they came out with a package called Essential Health Benefits. And the government said you have to cover these things. And I'll show you the schedule a little bit. So it intended to make people improve their ability to compare. And then finally, creating these things called exchanges. It's like Orbitz, Kayak, Expedia. When you're trying to buy airline tickets or hotel tickets, makes it easy, right? Plug it in, you say where you want to go, and it tells you all the different companies, US Air and Southwest Air, everybody, easy to shop. Very difficult to do in healthcare, but that's exactly what the federal government created with these federal exchanges. And, very important, you got to go to the exchange to see if there's any money from the government to help you. Okay, so let's drill down a little bit. So how are we going to pay for all this? No such thing as a free lunch, right? So three things. One, payments to providers from Medicare are going to go down. So they save money to be able to fund the ACA. Payments to insurers are going to go down. And new taxes and fees are going to be charged. At the end of the day, whether it's a provider getting less money, an insurer getting less money, or taxes and fees being charged, at the end of the day, all that's going to be passed on to the people who have insurance, to be able to, the people who don't have insurance, to get care, again, or get insurance. I'm not making a judgment on it, but that's essential. This is a redistribution. So people who have insurance are going to pay more, so people who don't have insurance can get access to care, which is a great thing. So let's take a look at the numbers. 310 million people in the United States. Where do they get their insurance if they're lucky enough to have it? 170 million of them buy commercial products like Kaiser, Blue Cross, Aetna, Cigna, United. Most of those get their insurance through a group, through their employer. Some of them buy it themselves. 55% over half. 14% qualify for medical assistance, Medicaid, which I talked about before, for low income, special needs, focusing on women and children. 46 million Medicare, which provides insurance from the federal government if you're over the age of 65 or disabled. And then 50 million people have no insurance at all, 16%. So if you jump from the upper right to the lower right, the idea is, let's get the 50 million down to 25 million. We can't eliminate the uninsured, but let's reduce it significantly by half. So how do we do that? Well, the first, healthcare reform comes along, the first is under the commercial. So we're going to mandate individuals and groups to provide insurance, or give them financial incentives to buy insurance, and we think that's one thing that's going to reduce the number of uninsured. The second thing we're going to do is we're going to increase the amount of money people can make and still be eligible for medical assistance. And that's the second thing. And actually, it's going to cut about equal. About half of the 25 that we're going to be insuring are coming from medical assistance and half are coming from the commercial population. The asterisk is a big problem. The Supreme Court, when they heard the ACA and said you can proceed, said, though, the federal government cannot mandate that the states follow through with expanding the medical assistance population. So they gave them an option. And a number of states, 20-some, said they're not going to take that option, which is a STEM lecture in and of itself. Mostly along partisan lines. A lot of Republican governors said, I'm not going to do it. A lot of Democrats said, I am. Well, that's a bit of a problem. How are we going to get to 25 million if 20-some states have said they're not going to increase medical assistance? Governor Corbett in the state of Pennsylvania said, I'm not going to do it the way President Obama wanted to do it, but I have an idea of my own, and that's being debated now across the states called LTPA. So hopefully they'll be able to resolve something there. Very much an eye chart here. The point is, this is a list of the benefits that the government says you must provide. Must provide. Doesn't say you have to provide it at 100% coverage, but you have to. You cannot say I'm not covering something on this list. So what's the good news? Good news is it helps me compare. Now I can look at products similarly. The other good news is very comprehensive. You want good coverage. There's a lot of stuff up here, from prescription drugs to hospitalizations to newborn care, mental health, ambulatory care services. There's the kitchen sink here. What's the bad news? The plan that you had before might not cover all these things. Therefore, the plan you've got now may cost more to be able to cover those new services. And secondly, some people don't want all these things. A 55-year-old single male is not that interested in paying for maternity and newborn care. But you have no choice in the system going forward. So what does this exchange look like? Well, what's that like? Flow, right? From Progressive, right? You plug in the number, and all these numbers come up with different companies. I never knew why. Why do you purchase? Why do you look at an insurance company, an auto insurance, and quote another auto insurance? That's a step lecture. But in terms of the exchange, this is an online system to do two things. The first is you got to go there to see if the federal government's going to provide you some money to buy insurance. And the federal government is very generous in terms of the household income level. So you'd be surprised, and your neighbors and friends would be surprised at people who will qualify for what they get for money to buy health insurance. So that's the first thing. So say you go in and you are entitled to get $100 a month. That's step one. Then you say, okay, what product do I want to buy? Well, we made it easy. We made them all metal. We said we're going to have platinum, gold, silver, and bronze. Platinum will cost you the most, and it'll cover the most. Bronze will cost you the least in premium, and it'll cover the least. But you can look at bronze for Blue Cross, Aetna, Geisinger, silver for Blue Cross, Aetna, Geisinger, United. It makes it easy, right? So you pick the plan you want. I want a gold plan. I got $100 in my pocket, and I get a gold plan. Third thing you want to do is, well, who do I want then? Let me look at Geisinger. Let me look at Aetna. Let me look at Blue Cross. And you can look at other things like network and your history with them to be able to make that buy. But it's very much like Orbitz and Kayak and Expedia. And if it works well, which it hasn't yet, I'll tell you in a minute, it really helps people shop for a very complicated product. So what do we think? What do the insurers think? Good news and bad news. Well, the pros for us is there's more customers. There's 25 million more people who are going to have insurance. Well, that's what we do. So getting more customers is good, right? Well, unfortunately, one of the cons is we're not sure we're going to be able to make any money. Not that you need to make a big profit, but whether you're a for-profit or a not-for-profit, you need to be able to make a margin to reinvest in your company and put money aside for a rainy day. And the rules, and there are many rules, regulation, make it very difficult for companies to be able to make a margin. So insurers are going to be really challenged with, good news, bad news. You're a gas station, they say, I'm gonna guarantee you 10,000 gallons a week that you weren't even getting before, but I'm gonna give you $1 for each gallon. And you're struggling between, how do I make money? That's where the innovation comes in. That's where STEM is gonna help people find a new mousetrap to be able to make it through. So let me tell you a quick story about the pharmacy business and what they did when they were faced with the same problem. And you all experience this in your daily lives. Where are the drugs when you walk into a pharmacy? Are they right up front? Way in the back, right? What do you gotta walk down? You gotta walk down the aisle to get to them, right? What are you walking by? Lip balm, magazines, hairspray, right? Well, guess what happened? The pharmacies found out they can't make any money on the drugs because the prices were too low. But the customers came to the pharmacy to buy the drugs. So they said, fine, we'll put them in the bag. And if they buy the lip balm, we can make money on lip balm. We can make money on magazines. We can make money on hairspray. And so that's what insurers are now doing, one of the innovative ways. You say, maybe we'll sell pet insurance. Maybe we'll sell disability insurance. Maybe we'll sell something else while you're our health insurance customer. Experience to date. Let me start with that. Radio, TV, media, we've heard about it. It's been a tough start, right? Customer confusion, everybody's upset, don't know what to do. Technology glitches, right? The system, you can't get on it for a while, and if you did get on it, you couldn't get through. That's getting better. You heard that quoted that 6 million people actually signed up, we think. Delays and rule changes. You wouldn't believe how many times they change a date, they change a deadline, and so just to keep up with it is really, really difficult. And we're divided, right, as a country. Right? The Republicans kind of want to do an about face. The Democrats want to go a step further. So we don't know if we're going forward, backwards, or sideward. And that's going to be debated when we see the results, probably 2014. So what are some examples of some innovative things that insurers are doing to do better in this new environment? Couple examples. Transparency. If you're going to pay a lot more for your health care, $1,000 deductible, $2,000 deductible, 20% co-pays, things like that, where's the information to help me be a better purchaser? So if I can get an x-ray for $100 to the right, it costs me $200 to the left. If I knew that, I'd go to the right because it's my money. But if the quality's much better at the person that does the $200, maybe I want to go there. Well, where's all that information? And that's what transparency is doing. We got a slow start, but we're catching up. Private marketplaces, real simple. Instead of Expedia, go to U.S. Airways. Where does U.S. Airways want you to search for airline tickets? Expedia? They want you to come to U.S. Air. Why? Because you'll get their products. You go to Expedia, you'll get everybody's products. So the Federal Exchange has everybody's products. So we're building private exchanges. So you come to the Blue Cross store, the Geisinger site, the Aetna store, so that you shop within the store. And there's a way to try to control market share. Health and wellness incentives. A lot of insurers and a lot of customers are partnering to say, if we're worried about promoting people's health, let's pay them. Put our money where the mouth, or whatever, you know. Put some money. And at the end of the day, provide $100 for someone to go get an annual visit. Provide $100 for them to fill out a risk assessment. Provide an incentive of some kind for them to manage their weight, their blood pressure, their cholesterol, their sugar level. And hopefully that financial incentive will help them not only pay for their health care, but improve their health and save money over the long term. Pay for performance models, you heard from Mike here. Health insurance stores, and I mean bricks and mortar stores. Blue Cross is a store in Dixon City, a store in Bartonville, where you basically go in, like you went to Boston, you buy a shirt. You go to the Blue Cross store and you buy Blue Cross. Or you go to Geisinger store and you buy that. Why? Because you've got to meet the customers where they are. We used to sell to all groups, right? A wholesale sale. So we sold 1,000 people at Procter & Gamble bought our insurance. Now we got to go get all 1,000 of them individually. And they might want to meet you on the web. They might want to meet you on the phone. They might want to come and talk to you. And if you're not out there where they can come and talk to you with a nice parking spot, it's a nice coffee, you're going to miss out. And then finally, technology, which obviously is critical to innovation. You know, you don't have an ID card, who cares? Here it is, it's on my phone. Pay your bill by phone. Send an email to your insurance company saying, hey, my claim didn't get paid. Can you fix that for me? Instead of waiting on the line for somebody to call. Reminders to providers. We heard before about are you going to get your colonoscopy at 50? Well, why not electronically automatically send a notice to the member and the doctor to help make sure we do the things that we should do to promote our health. So wrap-up slide here. ACA is just the beginning. The overall system needs improvement. There's opportunities that abound, driven by innovation, fresh minds and new approaches for the young folks in the room. Help us deal with access, affordability, and quality to improve that future healthcare system, because it's the only one we've got. And I just want to thank you for your attention.
Our next speaker is going to be Jim Youngkin. Jim is the Director for Health Information Technology for the United States Health System. He's going to talk about health information technology and innovative strategies in this new healthcare reform era. I also want to urge all of you, again, I hope you're jotting down lots of questions on your brochure, and hopefully we'll have plenty of time at the end here. Pay attention to, especially SEM students, pay attention to Jim's slides. I think everyone had terrific slides, but his may be a bit interactive as well. So I'm looking forward to his talk.
Really nice to be here and get a chance to talk to you about some of the things that we're doing with technology and healthcare. I wanted to talk about the moonshot, if I can figure this out. In health information technology, I've been in the field since the 90s, and I have never seen the amount of effort and resources that are going into health information technology as there is today. And there are several reasons for that. Starting back in 2004, if I can do that right, we had an announcement from George W. Bush that came to be known as the moonshot for electronic health records, where he said that every patient should have an electronic health record by 2014. So in 2004, it seemed like a long ways away, and here we are. So in 2008, there was an effort made to begin adopting health records, but it was very low, and most physicians didn't have these records in their practices, which is surprising because patients see that there are these computers in the doctor's office, but they're mostly being used for billing purposes and not for recording anything electronically. In 2009, ARA comes along, followed by the Accountable Care Act and something called HITECH, which is Health Information Technology and Economics and Clinical Health. So the purpose of that is to really kind of bring an alignment of all of these different resources that are needed to really have the impact for what we need today. So this is a slide that shows the framework and how these different pieces fit together. You can see that from all of the funding that was made available in healthcare, a lot of this went into the adoption of the use of electronic health records. You can see that there's regional extension centers that were funded to help physicians install electronic health records and get them to be used in those practices. There's a workforce training funding that was made available for the community colleges to offer classes in health information technology. There's these incentive programs that continue today for Medicare and Medicaid that will help incent the physicians to use their electronic health records. And then a program that I was very involved with had to do with the exchange of health information. Now this is the other term for exchange. It's not the health insurance exchange, but rather health information exchange. And this is a critical piece to enabling the information to go seamlessly from your doctor's office to the hospital, to any home health agency that you might receive care from. If you end up in a nursing home or your parents are there, Health Information Exchange allows the nursing home to have access to that information. And it also completes the picture by giving patients better access to their own information. So I thought it was interesting that right at the same time as the ACA was getting started, this gentleman from Computer World put together a list of the technologies that he'd like to see killed in 2010. And it was interesting that at the top of the list, number one is fax machine. And how many of you know that fax machines is the primary way that health information is exchanged in the country today? So it was very clear that what we needed to do in terms of accountable care and putting the resources into the electronic framework was needed and wanted by most people. So just I wanted to do a quick comparison of industries because a lot of times people say, well, I don't understand what the big deal is with healthcare because, you know, I can do all my banking electronically and I have my, you know, my MAC card and I can, or my ATM and I can get onto my web portal and so forth. And healthcare is catching up. It's not there where we would like it to be today, but we've made some really great strides in the last few years. So, you know, you have electronic bank records, electronic health records. Information is routed. You have routing information on your checks and you can transfer things around electronically. That's the role of Health Information Exchange. I mentioned the ATM cards. Well, today you can get a personal health record. In a lot of cases it may be tied to your physician's office or to your hospital system, but more and more we're starting to see personal health records that are connected to health information exchanges, which means that it doesn't matter if you go to a doctor in one healthcare system or a specialist in another, you can view all of that information from one single place. ATM networks allow you to share information across the country, pretty much wherever you go. We went to a foreign country a couple of years ago and we're able to get access to our funds. Where we're going with that at a national level is something called eHealth Exchange, or the previously known as a Nationwide Health Information Network. Again, it's very beginning of its process, but you know, you have a lot of people that spend half of their year down in Florida and the summer months here in Pennsylvania. And the ability to share that information electronically is critical to ensuring the ongoing continuum of care for those patients. You know, we have these credit bureaus, and you can go to Experian or one of those and look up your credit record. Today there are clearinghouses for things like claims. And of course, you know, the health insurance exchanges that are being put together today. In banking, you know, you have certain types of financial transactions that go back and forth, but it's pretty much, you know, based on financial transactions, you know, dollars and cents moving back and forth. In healthcare, we have literally hundreds of types of information that aren't even all in a numeric format or a textual format. We have WAV files and images that have to be traverse the network and understood by a lot of different systems. So it is an extremely complex environment when you talk about moving information from one place to another. And of course, we have the issues and concerns with privacy and identity theft. We have the same concerns in healthcare, but then there's also the issue of medical identity theft, where somebody takes somebody else's identity so they can get access to their medical history, or in some cases to medications that they shouldn't. I wanted to talk about the adoption life cycle, because this is going to be key as we transition through this period where you have physicians and hospitals and all these care providers that are moving from a place where they have less technology to beginning to use more technology. And you'll have these different stages that the folks go through, the innovators that want to try it first, and certainly I think that we're well along the way there when it comes to this kind of health information technology and use in the hospitals and practice settings. In fact, I would say that we're moving through the early adopting stage and beginning to get to a majority. And in this stage, we're starting to see more and more of the physicians using electronic health records. The program that I was involved with was focused on a 5-county area, and we started off with about a 40% adoption of electronic records by the physicians in that area. By the end of the 3-year period, we were up over 70%. So we started to hear a lot more of the physicians having a more positive attitude in terms of, yeah, this is something that we need to do, it's right for our patients, and I think we're going to start seeing the results of that. I think I'll just move on. So this is an example of one of the early adopters, I think, that anyway. I also wanted to talk about being ahead of the curve, because one of the reasons that we've been able to participate in some of these programs is because Geisinger has had electronic health records since the late 90s, and deployed it across all of the physician practices, and that kind of enabled Geisinger to do some things with electronic medical records that many others had not been able to do. And one observation about this curve, or being ahead of the curve, is that if you envision somebody who is up around the curve, they can see some things that you can't see back here. So some of the things that I'm very excited about that Geisinger has been working on are things like identifying gaps in care. So looking through the electronic medical record to find patients with certain conditions that maybe haven't had all of the tests that they should, and automatically placing an order in the system so that somebody contacts those patients and says, hey, we noticed that there's something here that we'd like you to take action on. And once you have electronic medical records, you're able to do some of these things. I'm also excited because the Health Information Exchange has information from all of the healthcare providers in the area, even the ones that are outside of Geisinger. So now, wouldn't it be nice if we could expand some of that thinking to say, let's not just focus on the information that we know about the patient, but let's look for the other information that's available that we didn't know about the patient, because you don't know what you don't know. And so by tapping into some of those resources, it helps us to be more effective at delivering care, because because the physicians have a better understanding of what's going on with their patients. This kind of just breaks down the different levels or magnitudes of healthcare, and don't need to get into the details here, but just knowing that at the end there's individual and family level that is involved. That usually involves things like personal health records and any kind of home monitoring that can be, again, connected back to their systems. The healthcare systems, again, using the electronic records, doing quality type reporting and meaningful use. And this all builds out to the regional levels, using the different technologies for exchanging information. You know, I don't know how many years we've been using email on a personal basis, but you can't use email in healthcare because it's not secure unless you get like special secure email systems. Well, in the last year, they started to develop this national standard for secure email, and they made it a requirement in this meaningful use. So in 2014, we're going to start seeing a lot more physicians' offices and hospital systems exchanging information through this secure email system. Oh, I had my boxes here. All right. So I also wanted to, this is an engaged patient, right? Over the New Year's, I was with a friend of mine at a party, and one of them where he had an issue with his chest, and they had him sit down on the floor and called for an ambulance to come over. Now he's okay, but and it was a sensitive situation because obviously we weren't sure that he was all right at the time. But I wanted to take a picture so bad because he's laying on the floor with these paramedics around him, and he's holding his phone up over his head, reading off his medication list to the paramedics that are there. And I thought, now there's an engaged patient. So, it's great that we can get this information to our patients that they can use them. My thought also there was, wouldn't it be nice if the EMTs could access the information themselves? But we'll get there next. So I wanted to end with a couple of career opportunities for those who are students here, because you may have an interest in technology, you may have an interest in healthcare, you may have an interest in an unrelated field, but your skills and abilities could be very well used in the healthcare field. We have physicians and nurses that are giving up their practice and spending time working through making the computer systems work more effectively, and that's their contribution. We have a need for project managers. Everything that we do is a project, and it takes a lot of time and resources, and so people with project management skills are critical to the success of this. We have people with heuristics, that their job is to look at things like the user interface and the cell phone and how data is displayed on the screen, and does it make sense, and can you get through that information quickly and effectively. And that's something that is very helpful for the whole industry. We even had a lady who took on the challenge of getting more clinicians engaged with the idea of doing the right thing for the patient and getting involved in sharing their information, and she started what's called the walking gallery. And I don't know if you can see on this screen, but these people actually have paintings on the back of their suit jackets that really tell their personal story in healthcare, and it opens a lot of discussion. So There's many ways to get involved. The old career ladder was a straight ladder, but now you can get into an industry and you can move horizontally, sometimes, up and down and across. And, that's the way that it is in healthcare today. What you're doing when you start into the field may not be what you're doing 5 or 10 years from now, but that's what makes it exciting. And there's many opportunities. It's not just a direct path. So I think that's what we have.
First of all, I'd like to recognize all of our speakers tonight. I really appreciate their comments. I think they gave us a lot of information moving forward. Also like to recognize other folks on the panel. Gordon Tina, who is CEO of Wyoming Valley Health System, is here, as well as Pam Langdon, who is a Regional Associate Vice President here at Geisinger Northeast. So with that, I'd like to open it up to all of you for any questions or comments, and we can have this very so please ask away. Yes, sir.
Given the unprecedented demand that the baby boomers are going to put on Medicare over the next decade or so, do you see any type of medical prioritization or rationing that is going to come about? And if not, what do you see with this heavy demand of this exclusively older population with a finite amount of resources?
All right,
I know it's a
Josh,
lovely
here.
question.
Well, I'll give it a shot. I think it's probably incumbent upon us as a society to begin to make some really informed decisions about rationing. Now, rationing is as a term, it's sort of pejorative, and years ago there was this talk about dengue pills. Nobody wants to see a loved one sent not to kind of care they deserve, but resources are finite. And I think that if you look at most every other country in the world, you're just looking north of the border to Canada or to Europe. Not everybody gets everything. Not everybody has access to everything like we do in this country. A number of the folks here talked earlier about the incredible costs that we have in this country without really the benefit of us speaking out. It's a heck of a lot of money. We don't have the benefit of all this that investment. So I think whether you call it rationing or whatever label you put on it, we are going to get to the point where the availability of resources to give everything to everyone is going to have to change.
Brian, any comments?
I think what we've seen is, as consumers, we read, we see television commercials, so we want the care that we see, or the purple pill, or whatever. That isn't always the best thing. So I think some of the innovation that between the insurance companies and the providers is, how do you look at best practice and really get what some of the things Mr. Rankin was talking about is pay for that quality, pay for outcomes, so that every patient is getting the care that they need, no more and no less. So I'll give you an example. If one of us has a knee or an ACL, or a lot of times people go right to an MRI. My friend had it, my friend had an MRI. That might not be what's necessary. And so I think getting back to what is actually needed instead of the whole battery of tests, which raises the cost for the providers, the health insurers, and certainly for the patient.
At the risk of being morbid, the vast majority of dollars we spend on people in healthcare are in the last year of your life, regardless of when someone dies. And so that there's a place to look that says, are we doing too much for my mother, especially end of life, elderly, complicated, multiple complications. We don't use enough palliative care in the country. So, cause and effect. I love the whole emphasis on keeping people healthy, but there's a news flash. We're all going to, at some point, leave the earth, and at some point they're going to spend a lot of medical expenses. So if we do it right at the end, there might be enough money to help those people who are just coming in that are underfunded.
So I'm just going to put my doctor's hat on for a second and throw a little fire into this mix here, and it's 2 points. is that there's been no significant tort reform. And in my opinion, as a practicing, thanks, appreciate that, no tomatoes, but the lawyers out here, but I'm going to say that if we're going to follow some rules, that we need some protection. And because if I'm the doc that didn't order that MRI, and that ACL is worse than it ought to have been, and then, God forbid, something bad happens, somebody's going to come after me. And maybe the system as well. So I want to throw that into the mix. And the second thing is that, unfortunately, despite all the technology features that we haven't necessarily developed the known factors of the trajectory of disease. And what I mean by that is, you can have a patient come into that ICU that you believe is actually going to make it, but the percentages aren't there. And the question is, who's going to give that patient a shot? We have to follow some rules, and we have some standards, we have some data, we have some evidence-based guidelines that we'll need to follow. But I think that's part of this learning process. We're learning where it makes sense and where it doesn't make sense. So that patient that comes in the ICU that may be 85 years old, that's actually been cutting their lawn and driving a tractor and going to the stores in great shape, was a Navy veteran who's got a hand of steel that has that aneurysm at birth, you're going to take to the operating room. Whereby someone from a nursing home that is unlikely to survive anything you do, you need to have a quote-unquote good discussion with the family about really what's the expected outcome. And by the way, that Navy veteran driving his tractor was a patient laying in the ICU that I took care of everyone. It made it. Other questions? Yes, sir.
I'm employed, but I am at retirement age. Some people think much beyond retirement age. At this point, I have health insurance through seminary, and I think I also have Medicaid. When either I retire or seminary chooses to retire me, how does the Affordable Care Act really impact me besides maybe taxes, which I won't have to pay if I have no income?
I'll take it. Medicare is largely unaffected by the Affordable Care Act. And it would have been nice to tell a lot of seniors about this a little early on in the process, because then they were very concerned. And I don't want to say totally unaffected, but for the most part, Medicare is not affected tremendously by the Affordable Care Act. There are some things they did to provide a couple extra benefits. At the end of the day, the seniors are secure with the Medicare program, other than the financial issue that was raised about the solvency of the program.
Other questions?
Question, I really like the idea of looking at this as a system now. To be an engineer by experience and education, and really think we're going in the right direction. So if you have someone who's not in the system, being uninsured, they're going to cost you more, it seems to me. And how much now, of those 50 million people, am I paying for with my health insurance? In other words, how much of the percentage of what I pay now is to pay those uninsured who really aren't paying anything?
Well, they're coming to your shop, but we're paying for it today. The problem is by default,
Right.
not by design. It'd be better to have them have insurance, so they go to the primary care physician, they go to the emergency room, and CORE takes care of them, the guys here takes care of them. But at the end of the day, it's past the time where maybe we could have done something beneficial for them. So it's not so much you are paying for it now, but can you pay less over time?
Yeah, I guess the question is what percentage of your health insurance would,
Compensate care?
yeah, would come down if you didn't have to pay for the uninsured population?
Right, I mean, it seems like that should.
I'd say it's probably a pretty big chunk, it's probably a pretty good amount.
Other questions?
I'll ask a question. What about the folks that don't buy in to the system? I guess there is the 1% tax that will be imposed on income tax, is that correct? For the individuals that choose not to elect. So where do those tax dollars go? Do they go back into the healthcare system, help fund Medicare or Medicaid, or does anybody know at this point?
Well, it's federal dollars, so I'm not quite sure whether they're going to redistribute it. I would hope they would redistribute it into healthcare, but raise that point, at least in the beginning, the dollar, it's $95. At the beginning, and that's for a certain situation. So unless you get that to be a higher amount, I hate to see penalties for people, the ROI is really not there. It's worth it to pay the $95.
Yeah, it's not
You
a.
can buy it later, because you can buy it later. You can buy insurance, later and get covered, so. But my assumption, and this maybe is a better answer than that, is that the tax would go to the federal government and, I don't know, goes to the general fund.
No, they'll spend it wisely.
Yeah.
Yeah.
Well, look at 10 million people are signed up right now. There are still 40 million out there that haven't signed up.
The
And-
30-year-old surfer.
Right, so if you're the young, person that makes, say, $50,000 a year, your tax penalty would be around $5,000. It would probably be cheaper in that situation to have the insurance, right, if $95 a month. So, I don't understand why folks aren't signing up for it. Are they just misinformed, or just developing technology glitches in the beginning, or?
Yeah, I think the website got, had a lot of problems.
Right.
Right. It scares some people away. We'll see. It's still, actually extended time, I think, a little more.
You're not spending any money on health, that's certain. You're not spending any, it's $95.
Yeah, better than that.
So if you feel like you're not spending any.
It's just, because we have just a bit of time left. We have two or three questions. Yes, sir.
Just a quick question just for the chair of the panel. As you people consult most of the finances of those positions, what can you tell the students in this room who want to be doctors in the future, what their lifestyle and future is going to be 10 years from now, or 15 years from now, when they're going to be applying to medical school? Is it going to be worth it?
Like, I would say any student that's interested, anybody that's interested in going to medical school should go into it because they want to practice medicine. They want to take care of people. Certainly, I think physicians will continue to make a good living, probably better than most. My opinion is that physicians going forward will not make the kinds of salaries they used to make historically, because as a number of folks said, more and more physicians are employed by systems. And again, it'll be a good living. It'll be a very respected and professional job. It's a very worthwhile position. Other physicians would know that better than I. But I don't think that you're going to see the kinds of salaries that physicians made in a generation.
I guess Dr. DeLuna and I would tell you the med school's pretty darn expensive. And in 10 years from now, what's it going to look like? And if we have a great need for primary care physicians and pediatricians, how's that going to be supported? I know you guys don't have the answer to that. But that's going to have to be part of the solution as well. If we want to develop strategies around, for example, an incentivized model where if you go to this med school for a certain number of years, you pay back that state for a certain number of years of service.
Well, hospitals doing that now. They're providing scholarships or loan payment for students who are going to medical school. As long as you come and work with us after your residency, we'll pay your loan and scholarship to fund that. That's happening.
Great. I saw a couple of hands up. Yeah, in the back.
I have two questions. The first one is, have you thought about, and this kind of relates to what Brian was saying, with the subsidies being based off of silver plans, if people are taking those plans and trying to access services, how are they going to come up with $5,000? Because you, as a provider, are going to want that money up front. You're not just going to rely on their good work and paying for it.
Yeah, I think, it's one of the challenges that's yet to be seen. I think we're both, preparing for a higher compensated care. The flip side of this, remember, part of the reason for doing this, and look at the positive sides, is that the more people insured, the more taking care of their health care, whether it's early in life, middle not the answer, because what we saw was this big divide on the costs going up and the funding for it going down. So we had no choice but to do something. And I think all of us might have thought about doing something different. The question I think is how we work together now to really take care of the community.
And the second part of my question, thank you, was directed to Brian. If you're not getting the numbers you need, that younger base, you're having to figure out your rates for 2015. What are those numbers going to look like?
Well, the rate setting is similar to a Texas Hold'em card game. In April, we submit rates to the government on what we think is going to happen the next year, and if the young, healthy people come in at a right pace, what we thought, we'll be okay. And so it's really a difficult thing. Right now in the market, you adjust your prices as things go by. So you take one big guess, one big bet. And if you guess right, you'll be okay. But if you guess wrong, you charge too much, you won't get any members. If you charge too little, you're going to lose a bunch of money. So it's really hard to manage. But I want to come back to your first question, because there's a little good news. There's bad news. Cost shifting is big time. It's here. It's going to take $1,000 deductible, 20% of this. But in the federal reform, there's a limit on out-of-pocket maximum. It's a big one. It's like $6,000. It's not $100,000 or $1 million, which it used to be. So everybody who buys health care has got a limit to what they would pay out of pocket. It's higher than probably they would like, but in the old days, you might have to pay, $100,000 for health care. I think the max is somewhere around $6 grand. So that's a lot of money, but at least there's some higher end that stuff. Yeah, but the hospitals, the doctors are going to stay. I don't know I'm going to get my $1,500 or for the deductible. That's a tough call.
And just one more question. As an insurer, do you feel like you may be a pawn in this game? Because as you stated, they made this health insurance reform, and your fee schedules are nowhere near the discounts that Medicare gets. So you're paying providers higher than, and they're kind of making their living based off of what you're paying versus what Medicare gives to Medicaid. So,
I stopped whining as a health insurer a couple of years ago because people just don't care. But it's a tough deal because we're the ones who are right front on the health care reform right now, and so we have to get the message. So when everything was delayed, we had to say it was delayed. When we took the product away that you were supposed to not have taken away, we had to tell them we took the product away. So pawn maybe, middleman maybe, but at the end of the day, that's the role we play, and we've got to be innovative to be able to do that better than the next guy. But it is a tough role. I will tell you, this is the toughest year. I've been in the business for 30 years. This is the toughest year for us to even make any kind of estimate of what business looks like next year. That's a scary proposition for anyone. Sure.
thank you for your answer.
Yeah.
I appreciate what you said about palliative care, and there was lots of pieces, but end of life is always going to be costly, but you could lessen those costs, you could address the baby boomers, everybody is going to benefit the healthier we are as a nation. Employers, insurance providers, we all know that. But and you alluded to this, some of the actions you're taking, Brian, is, obviously but obviously a big obstacle is the culture of reactive rather than proactive healthcare. Why should we get to that ACL and that MRI? Are you seeing that along the line of innovations? Are we seeing that, under these dire circumstances, we lag behind compared to a lot of countries in that proactive and preventative care. And I know it's hard because you're talking about the culture and individuals and the obesity and the smoking. Do you see any turnaround or any innovations on the horizon that might take that further because it would be highly beneficial? Do you see that ever changing or staying more status quo?
I think that one thing that the ACA doesn't include is it's incentive for the consumer, all of us, to try to take care of ourselves. Hospitals are penalized if patients are readmitted. But that patient who doesn't stay on the diet, who doesn't exercise, who smokes, who drinks, there's no financial disincentive for them to continue that unhealthy lifestyle. I think if us as consumers pay more out-of-pocket costs for an unhealthy lifestyle, we see a radical change in behavior. Until that happens, I don't know that we're going to really be able to affect change in a massive way.
And I don't know what each of you are doing that's a way to do it, but unless we all, not just all of us here, but unless everyone does that, and that wasn't built into the ACA, if that was built into the insurance product, that would be extremely beneficial, because that is, the patient engagement is extremely important. And some of the technology and the thing that Jim said about the iPhone is extremely important. But how do you get those people who, it's hard to get engaged, really engaged with them?
It's just a simple code. All we have to do is create a medical code that we pay for something that didn't happen.
But I think
So, so I'm gonna pay it, so that didn't happen. But there's not a code for that, right? So there's not a payment for that. So all we need is a code
Well, there's a little risk sharing that may go on with the patient at the top. How about you not go in the hospital and we'll prevent you, something like that. Well, I don't know if there's any other questions.
I think.
Yeah, I didn't get a chance to talk yet. So I'm gonna say something. But we actually had a number of care managers participate in our program. I know they play a big role in the accountable care organizations. And the care managers reach out to patients who have some of these chronic conditions and provide education and follow up with them to try to, get them onto a healthier lifestyle. And through technology, things like Bluetooth scales in their homes, they can, if they have CHF and they get on these scales, we can know automatically whether they've gained too much weight in a short period of time and follow up with a phone call to say, hey, there must be something going on here, let's talk about it. So I think there are some things that we're doing now and more of it.
Well, I really want to thank all of you for participating tonight. Just to have this kind of conversation together from all different walks of the healthcare arena, I think is terrific. And I hope that we could deliver some information to all of you that obviously we don't have the solution, we don't know what the outcome is, but perhaps more information is helpful. And again, thanks to all of you for coming.